I'd like to introduce senior doctor in psychiatry, Dr. Audun Irgens from Sørlandet Hospital. So, it's your turn.
Thank you. It's very nice to be invited here to speak to you about research on thought field therapy. Man, and doing a lot of work. He has written the collected works on science, on energy psychology, and has been to Norway a couple of times. Why do we care about science and statistics? Isn't it just enough to show that it works, as you very nicely did, Elizabeth? What seems beneficial does not have to be so. Or, that was a question. Just to remind you about ECTs. 100 years ago, high radiation doses for, Schlittaggicht, arthrosis, not arthritis, which I have. And they gave high radiation doses, and what would happen some years after? Not very good. And common skin problems too. Neuroleptics, as you know, in small doses it might be good for some people, but not as much and as high as we use today. This is a terrible story. It's local anesthesia given intravenously for people after cardiac infarction, having arrhythmias. Well, it calmed the arrhythmias, but it killed the patients. We learned some years later. So we need science to find out. Okay. How do we enhance scientific knowledge? We have single observations. We'll come back to that. Serious. Single observation, that is the woman with the water phobia in 1980 or 79, when Callahan started. It was a single observation on which he built series of observations. We can do retrospective studies. We see something and wonder, haven't we seen that before? And we go back and look at our patient material, and well, we can find a trend here. Build on it and make prospective studies. We define some criteria and see on the next 100 patients we treat, will it work as we postulated it would. Then we can have randomized controlled studies where it's by chance if the patients get thought field therapy or another therapy. We are now getting away from what we think it will be until what can we really show. And meta-analysis is just taking more of those together. Some demands to the RCTs. Known or hidden randomization key, that is, will I as a researcher know who is to get the therapy or not? If you two come today in a row, you are number 15 and 16 in the project, and I know the key, and I have found out that you will be easier to treat than you. If I know the key, I will take you for the thought field therapy and you for the control group. So that's the question. Waitlist as control, as we had Mats. Blinded evaluation, we didn't have that either. Have that in the next study. That is the one finding out how is the score for this human being. Shall not know which kind of treatment this patient has got. Shall we have an active treatment as control? And if so, manualized, so we know what's being done? Should it be the gold standard, the best treatment to compare? What kind of statistics should we use?